And thanks everyone for joining us. We're very excited today. We have a rock star in the midst here today to talk with us about HIV in youth. Dr. Lisa Hightow-Weidman is our speaker today. She's professor of medicine in the Institute of Global Health and Infectious Diseases and professor of health behavior in the Gillings School of Global Public Health at UNC Chapel Hill. Dr. Hightow-Weidman is director of the Behavioral and Technology Lab, which he lovingly calls the BAT Lab. I'm sure that's a fun joke at UNC, and is an expert in the development, implementation, and evaluation of digital health interventions to address the HIV care continuum for adolescents and young adults, particularly among sexual and gender minority populations. I wonder if there's ever an emergency, is there the bat sign like in Batman that goes up and says, "We need help." Lisa has developed digital health interventions to address uptake and adherence to biomedical HIV prevention technologies, as well as intervening to increase HIV diagnosis, linkage, and prevention and care for sexual and gender minority youth. She's received many millions of dollars of funding from the National Institutes of Health, the HIV AIDS Bureau, and the CDC. In spite of all that, or in addition to all that, Lisa is also a practicing clinician. So she knows very well about how the gap is between determining what to do from data and the uncomfort and sometimes struggle to work with patients in real time, and has been providing care to youth living with or at risk for HIV at UNC since 2001. We are deeply in your debt, Lisa, to have you here. We love you. We want to hear from you, and we're looking forward to what you have to say today.
Wow. Awesome. Let me make sure I can share this appropriately. That still work? Okay.
Looks good.
Awesome. Okay. Well, that is like the warmest introduction I think I've ever had. And so I wish I could record it and play it to my wife and family. So they now think I just do nothing, since all I do is, I'm working from home. So I don't think they quite get it. But I'm excited to be here. Obviously, I really do wish that I was there in person. It's just, here we are. So I'm going to try and go through a little bit of kind of the work we do in the BAT Lab. And again, it's a team effort. There's so much collaboration that all of this work that I'm going to present is related to. I see some of you on the call who are either part of the BAT Lab or part of the collaboration. So thank you for listening to me, even though you have to listen to me in meetings and other things. So I appreciate it. And then there'll be plenty of time for some questions. So let us begin. I think any talk on innovations in digital health should really begin with sort of just a little nod to the fact, of how pervasive mobile phones are, really kind of, globally across the world. And certainly when we're thinking about youth in terms of their access to, engagement with, and use of social media, as well as mobile tools. I thought, again, this was an update that, on average, we look at our phones, we open our phones 160 times a day. So, again, if you could, somebody smart out there who enjoys math, I do not, could figure out how much time we spend just opening, our phones, and that could be done, doing other work. For me, perhaps exercising would be a good thing. But again, across the world, social media is really pervasive. And so when we think about, MHealth and mobile health, it really is just another way to connect and deliver interventions, because it is such a pervasive medium. We think about, sort of digging even deeper, social media, again, we use this term quite a bit, in terms of how we connect with each other. And, this is most recent data looking at social media usage around in the age group of 12 to 34. So a pretty broad age group. But again, what you can see in this is that, decreasing in some of the platforms that are, skewing towards my demographic. Facebook, I see Rafi is on the call. I know he's on Facebook. He posts, a lot of dog pictures pictures, dog, food, and Jewish holidays. That's really the main post from Rafi. But, you can see with some of the other groups, rise in certainly in TikTok and, some of the other kind of Instagram, is really kind of where, young people live. I put a couple of these up. This was the first Twitter post, the first Instagram post that came up. And then this was, if you really think of when social media started, it really did start with, I think, kind of, Samuel Morse 200 years ago. And if you actually had made his Morse first sort of Morse code communication a tweet, it would have been, what hath God wrought. So I think he was pretty prescient in his use of communications across places and spaces. So why MHealth? Again, I think, for any intervention, for any behavior we're trying to change, for any, solution, we need to kind of think about, why are we actually thinking MHealth is the behavior, the tool, right? It's not innovative anymore in some ways. I mean, some facets are. So, we used to use it because it was really cool and we'd get innovation points on our grants. But really now, you have to kind of make the argument as to, what is the behavior you're trying to change? Why is MHealth the right solution or kind of an additional solution? Why is it better than other solutions? And then what has already been done in the field? Why is this solution better or building upon or learning from or enhancing something else? And again, there's all types of different, MHealth tools. We've certainly progressed across from the basic phone, feature phone, smartphone, but even within this, in these sort of models, there are older smartphones that can't do as much, process as much, have as much memory as some of the newer phones. And this can be very important depending on the setting in which you're working. In addition, data is a really key piece. And so how people, pay for, sometimes the data is the limiting factor, not actually the type of phone. And certainly we see this in some of our, the work that we've been doing in South Africa and other global settings. So, understanding the technology that your population has access to is really critical when you're starting to think about what you want to do and how you're going to do it. And there's lots of technology-based approaches these days. Again, what started out as SMS or Morse code, I like to say is, there's so much you can do. And we haven't even really probably begun to, really grasp the full capabilities that our phones have. I mean, my phone now is, certainly tracking me. It heard me talk about, Rafi, and now I'm going to get like a Yom Kippur ad on my phone because it knows, that I mentioned that. So, it's sensing us, this idea that, that we're really tapping into all that, that these MHealth tools can do is certainly, we're not there yet. But at the same time, we may not need to be, right? There's a lot that we can actually do, really just using phones as a connector, as a bridge, as a way to connect with people and kind of motivate them to do things. So I think thinking about these approaches, understanding them is really important. And then I think the key piece is what features are critical to an intervention engagement. I spend a lot of my time thinking about how to engage folks, particularly young folks, in MHealth tools, either as an adjunct to an in-person intervention or as part of the intervention itself. And I think what we know is that there's been a lot of work looking at what are critical engagement features. And again, a lot of these are youth focused. Some of them come from work we've done in the HIV prevention and care space. Some have come from other health conditions. Again, kind of the importance of understanding engagement as a broad concept in MHealth cannot be kind of understated. But certainly tailoring of interventions, again, we see this in in-person interventions. The more tailored the communications and the information is, the more responsive. So fostering social and peer support, again, kind of, certainly, having, the trusted opinions of those that you rely on and seek to get information from is critical. And that's why, most of the time of our young people are on social media. It has it in its name. Inclusion of game-based elements. And again, this is a whole kind of area of work, but doing something to make something fun. Nobody likes to do stuff. I see I toned down my language for you all. Nobody likes to do stuff that is boring or is, menial. I would, do much more IRB, protocol amendments if they paid me, or awarded me in badges. It's not fun. If it's not fun and you don't have to do it, you may not. And so the game-based elements is just, it really is an engagement piece. And again, we'll talk more about it. I don't think it's all of it, but it is probably a requirement that if you're going to ask people to do something, they have to get some level of enjoyment out of it. Provision of self-monitoring and feedback, again, which is, certainly seen in all different types of interventions. Again, feeling like you're getting something back. We see this in all of the other kind of apps that are in the space around behavior change. Any of your fitness pals or your Nooms or your, mindfulness stuff, everything is giving you feedback on how you're doing, encouragement, et cetera. Reminders to log in, reminders to do things. I can't imagine how many meetings I would miss if I didn't get a reminder, okay, you're scheduled to talk to somebody today, or, oh no, you need to go to the dentist, and the ability to, again, I think my kids would probably have scurvy if I didn't, know that I needed to take them to the doctor once a year. So, it is important, and all of these things really are critical. And I think we know this. We don't need to ask anymore if these are important parts of our interventions. They are. Similarly, we've asked a lot of times in a lot of ways to a lot of different groups of youth across the US and globally, what features they want in their interventions. Now, this doesn't necessarily, they don't go exactly hand in hand in what's been shown to engage people, because sometimes you think you want something and then you actually, once you have it, you don't use it. But when we ask people what they want, they say they want to have connections to their peers and to providers. And again, providers is a broad, is broadly kind of defined, medical providers, nurses, social workers, case managers, care navigators, patient navigators, peers. So all of these things kind of fall into that. Inclusion of the reminders need to be discrete, to some extent, people want, just reminders that either they can customize or that, reflects where they are in their kind of, journey. And so the ability for, reminders not to necessarily say time for Truvada or, and again, I'm not, no conflict of interest. I don't work for Gilead. So, but, time for, for this medicine, they may not want that. Maybe they do, and that's okay. But the ability to allow for customization of that. Again, comprehensive, holistic, accurate information. Not everyone needs to have HIV shoved down their throat every second of every day, nor do they want it. They don't live and breathe HIV prevention, treatment, all of that like we do. And there's so much more information that is relevant and useful in their lives that can improve their quality of life, improve their engagement in healthcare in general, which can then also lead to engagement in prevention and care. And so, these youth recognize that. Again, like I said, games, rewards, incentives, something to make it more, more than just work. And then again, careful attention to privacy and confidentiality, which again, for them really just means that they have some control over it. Young people, again, aren't as worried as I think, others would believe around, getting messages through their phones. They do a lot of things and look at a lot of things and go to a lot of sites on their phone that they wish to keep private and confidential. And so ensuring that our interventions allow them the same capabilities to include their own logins and passwords, include screen lock, include timeout features, et cetera. So, again, specific populations, this may differ, and that's really where, again, getting more information, but I think you can sort of say as a whole, this is what you're going to hear if you start to ask people what they want. And when we look at, innovations in digital health prevention, this is just a short, list of what's already been sort of done and is being done, is being evaluated in terms of prevention, care continuum outcomes, right? So, and the yellow ones, the red ones are work that we've done in part of the work that I've been leading through our network studies or through behavior and technology lab. And again, these are just the ones that are kind of, a short list. And so if you have one that I didn't put on here, it's not in it just for space. But I think the point is, within each of these categories, there's a lot of different apps or mobile optimized interventions, right? And there's not a lot of interventions that overlap in these different testing, and care and prevention continuum silos. In terms of technology to support viral suppression for youth living with HIV, again, these are just two examples of work we've been doing, but again, very focused on kind of the population living with HIV. So, and one is being tested within ITECH and one is kind of within BAT Lab. ITECH is sort of an attempt that we were making to try and really understand how technology could address some of these prevention and care continuum outcomes. And ITECH is a U19 that is funded through the Adolescent Trials Network, the ATN. And we have 10 plus studies. I say 10 plus because we had a couple others added on that aren't on this, but the idea was to try and understand how youth could be using technologies to address prevention and care, while also kind of ensuring that we were looking at some of the psychosocial and structural variables that impact engagement at each of these in each of these sort of silos, I guess, to some extent, right? We're in the last year of the ATN, and I'm happy to say that almost all of our studies are close to enrollment. I'll give a shout out to TechStep. I saw Kathy join. So TechStep is one of our studies for gender nonconforming youth, and it just finished basically enrollment. So yay. But we'll have more data, kind of efficacy data on these studies. But I think bottom line is that there'll be a lot of data on MHealth interventions for addressing kind of the needs of youth at specific places in terms of HIV testing, PrEP uptake, and we'll be able to look hopefully at more cross-project outcomes to be able to really, again, move forward. And I'll talk about kind of my vision for how we move forward from having these single, multiple interventions testing various apps, addressing singular or at most dual pillars, to much more responsive, dynamic platforms addressing kind of the continuum of care. And why do I kind of move in this direction? Well, there's just significant challenges that we have in terms of achieving broad dissemination and sustained impact. Again, full disclosure, none of my apps have been widely disseminated. Some of my apps are dead. They were beautiful. They were lovely. They actually showed some impact, but they aren't sustainable because of the model of building them. And so the company that was, that we were working with, or whether it was internal or external, it was really a fee-for-service model. And with a fee-for-service model, when the fees run out, they're not going to continue to work on it, to adapt it, to enhance it. And so we need to kind of, again, think about how we really can move the field forward in terms of dissemination. And again, these are, the current, again, model, and user engagement, it's often low, but we, instead of kind of learning from that and doing something to augment it, the intervention is deemed ineffective. And again, I don't know if that's the right, model. Content development and management are highly inefficient and time consuming. Writing content for digital health interventions is really hard. You have to use a certain voice. You need to keep it up to date. And again, if you're going to align with kind of what I said before about it needing to be holistic and not just focused on prevention or care or whatever your outcome is, it's a lot of content to write. And so, funding us, investigators to continue to write this over and over the same information is not efficient. Again, new scientific knowledge, again, we learn, all the time of new things that become, effective. Long acting, again, when we launch certain interventions, again, we may say in different pieces of content, again, we may refer to PrEP as once daily or, oral PrEP. Well, what happens when long acting injectables are approved? Do we have to go back in to the intervention to adapt that content? How do we find the exact pieces in our digital health intervention where we mention it? How do we go in? Is it even possible to kind of make a change? What if the study's kind of, you're already enrolled, will that impact how the app functions? So again, but, we need to make sure that we think about this, because youth, if they read something and it's not up to date and it's not, highly relevant and to what they've already read on in their social media or on, wherever they're looking, then we've lost our trust and credibility. And again, there's been significant impact, investment in NIH and, private companies, a lot in creating digital health interventions for HIV. Again, they've invested a lot in me, and I have not, I don't record, I guess is recorded, but, in my mind, I have not done as much with that money as I should have, in that I don't have a platform yet to show for it that has been widely achieved. And I think we need to really think about more reuse, sharing of our investments to really, get things out to the population, and in a more equitable and expeditious manner. Similarly, again, I include this slide because I have to figure out a way to include Dolly Parton in at least one of my slides, and so this is my way of doing it. But the idea that there's one one magic app that would work for everyone, that embodies everything that they need for the kind of entirety of the time that we even do our studies, 12 months, is unlikely. And so, we need to think about, how we can create interventions that are tailored to spaces, places, and changes that, particularly if we're dealing with youth, again, what they're into today and tomorrow is, could be very different. What they prioritize in terms of information, again, related to their health is very different. And so when we enroll someone in a study that's meant to increase, for instance, HIV testing, and then, we expect them to be in this study for 12 months. Well, what if during that testing, they decide actually they want to start PrEP? But that intervention actually isn't about PrEP. It's about HIV testing. So, are we providing them with any information on PrEP adherence? Well, probably not. But do we know youth need, PrEP adherence information? Certainly. And so, how do we really think about that? What if they, again, they stop using, PrEP, and so they think they don't need to use whatever intervention they're on? How do we kind of re-engage them throughout kind of where they are? So again, I think our, my focus has been really in thinking about how we can actually start to do this and do this, in a meaningful way. And therein begins kind of what I'll talk about a little bit is sort of our development of a platform called Health Empowerment. And this has really started to become more of our flagship platform for development because, it's been around a long time, and we've been able to kind of think about it in a way of adaptation and enhancement versus starting over and over again. So Health Empowerment 1.0 was sort of my first grant. Actually, it was a training grant at K23, which then kind of turned into an R01. So it's been around, as long as I have to some degree, and we won't give the exact dates and times, but a fair amount of time. It started as a mobile optimized platform. It started before Facebook, even I think before MySpace, for those of you that are old like me. And so when it was first developed, it was really an intervention that was meant to be kind of a computer delivered intervention, or e-health, as we used to call it, where somebody kind of engaged with the computer and asked, did some questions, quizzes, information. They got to ask me questions. I was the kind of expert. When I was logged on, there would be, a blinking light that would say like the doctor is in. And that was, we thought that was really, sexy and cool. And, mid kind of development of our intervention is when MHealth started to take off. And so, the first thing that we were able to really do was make the intervention mobile optimized, meaning when you went to the website, it didn't look like crap on the phone. It looked like it was sized and everything for the phone. And we did our study, again, this was pre-PrEP when we did this. And so our outcomes were really around condomless anal intercourse. But, one of the, I think, things that I'm most proud of is that we created from the very beginning a status neutral intervention. And so in our first study, again, which was pre kind of U equals U and pre kind of, treatment as prevention, we believed that, putting folks who were living with HIV and at risk for HIV together was really going to be the only way, in a social interaction way, that we would address stigma. And so, and we actually did find that some, significant reductions in condomless anal intercourse, which is the main outcome, but also that we did see changes in stigma, in disclosure, and provider communication, and access to care. Again, the interesting thing and the kind of the important thing is that, engagement, as not as surprisingly, was associated with better outcomes. And we had some challenges with engagement. We have learned from that and are continuing to build on that. In the interim, between kind of HMP 1.0 and HMP 2.0, there's been a lot of work that we've done again on apps and through ITECH and other things that have tested, again, different either kind of health behavior outcomes or have included different pieces of digital health interventions, including, adding in more gamification, more interactivity, avatars, self-monitoring, more multimedia content, medication tracking, et cetera. So I'm not going to, bore you with all of the, things leading up to it, but it's led us to where we are now in health empowerment, which we call HMP 2.0. The key thing with HMP 2.0 is for us was finding a development company that actually believed in the same vision that we did. Basically, like, you're never going to get rich from doing this, but there's value in actually doing things because you believe in them. And so One Cal Standing is our technology partner, and they really have kind of invested in our idea that to get to a place where we can create a sustainable solution, we need to just continue to build on it and learn and provide it to folks that maybe don't have big budgets to build new apps, but maybe are on training grants, and to start to really kind of figure out how we can continue to leverage advances so that everyone getting the platform is getting kind of a bigger and better model. And so we sort of use this phrase as it being a co-op model, but it really is this idea that if I write a grant that's going to enhance a certain feature of it or add a new feature to the platform, then that feature becomes available to every person, every research group that's going to be using it next. So it's not like you start with a basic platform that has the features that we know are required, and then it allows for much more creativity and true adaptations and enhancements to the population, because you're not worried about building a forum, for engagement. You're not worried about building, a resource content library. You're worried about adding the important information or adapting it or making it, building out the gamification features. So you have a little bit, more creativity and flexibility time by, starting from something that has some legs. And what's our, model? Why build a new, build on versus build a new? I am not Apple, clearly, obviously. But, I think, this comes from, I had gotten a grant review. We all get grant reviews sometimes that are a little painful, but, I'd gotten one recently that was basically like, HMP has been around since 2011. Why are we still seeing, applications using it? And I thought, well, thank you. It's been around, for 10 years, which means, to me, that means something, and so, when I think about kind of the first iPhone, which was 2007, and the features that it had, and then the changes and the capabilities, that it keeps adding on, it's still called iPhone. It just has a new number, right? It's not, they haven't changed the name. They haven't, said, all right, well, this, this version, people didn't use, or this feature, isn't well used. So they didn't scrap the whole iPhone. They just scrapped that feature, or they made that feature better. And so in my mind, that, to have a platform that has been around for, 10 plus years is actually a sign that there's still an investment in it, and we're continuing to learn. And that, for us, that is actually a more of an innovation in some ways than kind of a detriment. So what are we doing now with HMP 2.0? Well, I mean, the first thing we obviously had to do was turn it into an app. And so it's now available as an app, for Android and smartphones. I'll go into a little bit more of the features, but this is a map of some of the studies where we're doing it. And I think, I'm most proud that two of the applications are K awards, which means that, we're allowing junior investigators to actually be able to start with a fully developed app for their population, which, for those of you that have applied for Ks and other types of, it's very, very little funding, for the study. It's much more to support the investigator, which it should be. But again, we're able to kind of give them a fully formed app to use. Some of this is for some end the epidemic work again, and then you'll see a project that's near and dear to my heart, Represent, which is actually an LA project. So a shout out to folks from that group that are on the call, but and I'll use some of the screenshots from that app. And Represent is an app to increase PrEP uptake among youth in Los Angeles. So again, I won't go into every single detail, but just to give you kind of an idea of the approach for health empowerment, these are all the different features that it includes. So, in terms of kind of resources, which are articles and goal setting, and I'll show you some of these things, but the idea is you can see this sort of home screen, this is, has a lot of sort of modular elements. It's sort of created to be modular so that you can kind of plug and play what folks need for their, for their intervention. If they don't have anybody to connect with, we have our representative, which again is not a name I came up with, but I love. So again, to connect, if you don't have that, you can just remove that and change the way things look. And so, but again, it's this sort of modular approach. This is just sort of 3 different versions. You can see how it looks very, very different, but it's still modular in terms of, a version for South Africa, a version for the US, and then for Brazil. So different, again, versions of how you can, customize it. And again, some of the, the money that groups are investing is to do this, how customized they want it to be. And that's, something that it's nice to be able to actually kind of use money to make things customized rather than to have to kind of build. Again, we've been working to increase our kind of ability in forward thinking of, delivery of more adaptive interventions, which requires kind of, tracking, self-monitoring and messaging. And so again, the ability to monitor different behaviors. Again, this is sort of fully customizable about what behaviors make sense. Analytics, again, this is sort of I would call it kind of a first level approach at our analytics. It's something, again, that I'm trying to invest more time and thought into making the analytics a little bit more kind of exciting and in line with some of the other things that we can see. But again, you can see how, this is, you can look at behaviors and adherence and make, kind of self-monitor and make decisions around kind of engagement in behaviors that may place you at risk. And these are some of the reminders. Again, they didn't come through as well because I think my screen background, I apologize, was dark. But what you can see is that, again, in this one, it's the reminder is for their medication, it's a cell phone, and it says, get all you need to start playing. Well, the strategy that they chose to get a reminder around was playing on their phone. And so their message that they sort of crafted, or the app will kind of give you an idea of a potential message, and then you can use it or not, or change it, but is around playing. And so tying behaviors to medication behaviors to habit building of things that you do also then ties to the reminder. So this is our goal setting feature. This is a new feature that we've just, again, been building. But the idea of, creating different goals, again, around, whatever behavior change your sort of the intervention is working out, but also other behaviors. This is again, for our PrepResent app. So this is around PrEP uptake. And so you can see this goal, within each goal, there's milestones, there's tasks, there's connections. Again, all of these kind of put link to other information within the app. So again, the connections ask the PrepResent community for, recommendations for a good provider, different steps and different activities and things that folks can do. And again, this is a customizable thing. You could, again, have any topic, any goal. So, you can see how, again, if you want to, target multiple areas of behavior change, how something like this can be useful. Care navigation and ask the expert. So again, connections to care, something we hear about, something that, again, folks sometimes use, sometimes don't, but a way to kind of schedule meetings or chats within the app or outside. We currently kind of link to external video conferencing. We've talked about embedding video conferencing software within the app, but again, there's some issues in terms of privacy and what different institutions will allow. But a way to connect. And then an Ask the Expert feature. Again, I know you're all in LA, so I'll just highlight this is our LA provider, who's an expert. Jonathan Warris is our one of our experts here in LA. So again, this is also something that can be customized. It can also be preloaded with with questions that have already been asked, because the questions and answer features is all anonymous. So, you can kind of start and have your app filled with all kinds of questions that have been answered by lots of different experts in lots of different places in the, around the world. Gamification, again, we use sort of a badge system that can also be tied to real world rewards. So when you get a certain badge, you get a swag bag, that's tangible, or can truly be fully a virtual system. Again, it's all tied to different rewards. They can be, again, use the badge sets we have, or again, depending on, what folks want, can be customized. The one on the right is actually customized to our South Africa project, where the badges are in sets aligned with different kind of areas. So beauty, career, et cetera. Our South Africa study also wanted much more customization. And so we've built an avatar builder, and you can see how much, pieces of these unlock. Again, this can be extravagant as simple or as extravagant. And again, now that this is built, if another group wanted to use this, it's available in terms of customization of different avatars. We're working to create one for US populations as well. Hopefully that then would be part of kind of what's available. And then study management is obviously important. And so having a way to engage with youth through the app in terms of collection of kits, management, analytics is part of kind of the dashboard. So never being satisfied, moving forward, we want to, also think about moving from HMP 2.0 to HMP 3.0. And so, really in 3.0, it's now taking things and moving them into kind of, a much more, I think, digital transformation kind of world. And again, really trying to streamline adaptation, thinking about content and bi-directional channels for content contribution, delivering interventions, again, that continue to be much more relevant and engaging, to facilitate broader adoption of DHIs, and to be able to really kind of facilitate tailored content management at scale, which again, currently is not achievable. Even within our current platform, every time somebody wants to use it, we're sort of having to reload whatever new version of the platform they have with, kind of the current content. And so I think really understanding how to use content better and manage it better is really important. And so what we've started to do is really kind of develop a mapping strategy. What do we have? How can we tag it? What metadata exists sort of in terms of the type of content, when it was written, what topics it's covering, what, behavior construct or change mechanism is it targeting, what level? And by doing this, we're going to be able to hopefully develop a content repository. And this is just a picture of what the content kind of looks like in our app in terms of different categories, but the ability to create a content repository that's available so that, if you're doing an intervention for, young Black trans men in, Los Angeles, you and decide, these are the tags of content that you want included. You can get kind of the app preloaded to what you want versus sort of the entire one and then having to kind of call through. In addition, it would allow us better to be able to actually make changes if new information becomes available by searching how many articles mention Truvada, and do we need to go in there and actually then change all of them at once to say Truvada and or cabotegravir or something. And we're trying to, again, move towards thinking about how then once that content is mapped and tagged, et cetera, creating recommendation systems. And those systems can be based on sort of rules-based systems where we ask questions and surveys and then kind of deliver content that matches kind of what people say. But it also can use machine learning. And I'm no machine learning expert, but we're partnering with folks that actually do this so that you can actually get dynamic real-time tailored content pushed, and content meaning not just an article, but messages, activities, goals, all of that pushed based on, sort of your user profile of sort of, other users similar to you, as well as based on what you actually are doing or looking at in the app. So, this is not new. This happens anytime you turn on the TV and go to Netflix or anything else, right? Or Amazon, anything you do is being, tailored, and you're getting recommendations based on that. We just need to figure out how to do it in health, in health behavior change. In addition, social media data mining, again, this is an ethical issue, right? Of how much information we want access to, but again, this is being collected all the time by people who are not using it for the purposes that, that are really meant to actually improve kind of lives, which, that's, I think, all of our goals right at the end of the day. And so I think, we need to be thinking about it. And a recent study did sort of look at social media data, and there's been others, but again, certain, postings and searches were associated with offline behaviors. And we know this, right? We know this from a lot of good and bad things. We know this from postings around, bullying that leads to, suicide. I didn't realize it's called bully side. My son did a presentation on it. So, but we need to be thinking about how we can do this. And I know there's a lot of researchers, out there, that I work with as well, that are thinking about this. And we need to be kind of, thinking about how we can, do this in a way that is obviously ethically, paying attention to ethics from the very beginning, but not letting us, not letting that stop us from thinking about it. And again, that moves us to, all the different things that phones are recording and doing, and how much information can be learned from, what we do with our phones, how much we text, when we text, who we text, what other apps we use. All of that predicts, our level of depression or, substance use or other things. And so again, how can we use that to think about delivery of more adaptive interventions? And, again, these are really just delivering the right intervention at the right time, when you're kind of at that sweet spot between somebody who's vulnerable, the opportunity state and the receptivity state. And will this, to me, this is sort of where we need to be. This is, how we can really maximize the technologies that we have. Just in the home stretch, just, talking just about one recent study that we've been doing to sort of start thinking about this is the POEM study. And the POEM study is PrEP options exploring messages to plan for sex. And the idea was to use ecological momentary assessment to actually understand how well or if youth could plan and predict sexual encounters. Really thinking about on-demand PrEP strategies, but I think it applies to all different types of prevention and treatment modalities. How well they can plan for attending a visit, every 2 months, and all the steps in between is as important as how well they can plan to take medication, 2 hours, 2 to 24 hours before they're going to have sex. And so the first part is an EMA survey of 120 youth daily for 2 months. And then the second part is to use all of that information really to understand if there are certain predictors that youth have that make them better predictors of the sex they're going to have, whether it's individual level, neurocognitive, neurodevelopmental factors, or, partnership factors, or other kind of structural related things that lead to better planning. And again, to then take that information back to youth advisors to think about some messages that, and messaging and sort of timing and nature of messaging is part of a just-in-time intervention. And so this is just showing our, again, 10 questions. Everybody gets the first 4. If you, and basically the first 4 are asking about your prediction that you're going to have sex in the next 24 hours. And then the last 6 are if you had sex in the past 24 hours, about some relationship factors that might have impacted kind of your spontaneity and planning. Again, this is just a shout out to the study team that did this study with us at Bat Lab. And, we enrolled 120 young MSM, followed them for 2 months. This is the highest retention I've ever had in any study, and it's real. I did double check, but 99.2% of folks did the baseline in 2 months, and our EMA completion was 98%. So, which is insane to me, but the youth really, they did this survey. Again, we have 6,500 daily responses. 12% of those are related having sex the prior day. And I think, again, just what we start to see is that, when you look at of those, sex events that, how long before did you know you were going to have sex? It's really, again, a third less than an hour. Really only 20% knew 2 hours or more ahead of time. So again, you can see how this can start to plan some more just-in-time interventions. The other thing we're really thinking about, again, is engagement much, much more. This has always been sort of an after the study thing. Oh, everyone dropped out, or, they didn't use it that much. You look at the kind of the paradata or the analytics, as it's going, but you don't do anything with them. And so I think, we really more and more need to be defining what we mean by engagement a priori, and how we're going to measure it, and how we're going to, and what we're going to do about it. And I think more and more we should be doing something about it during the intervention. We shouldn't be creating these really amazing interventions and then assuming that nothing is going to stay the same in an entire year. Again, I go back to the Apple example. If you told, the folks at Apple that, you're going to, launch iOS X, Y, or Z. And, even if you figure out how to do something really cool, that's going to like increase your revenue by X amount, you can't do it for 12 months because we're in the middle of a study. And, they would, well, first of all, they wouldn't probably talk. I can't get a hold of anyone there, but the point is that no, it's just, it doesn't make any sense. And so I do think we have to start changing the model, and it doesn't mean that we don't do rigorous science and look at, but we have to, address the fact that, rigorous science that is flexible to advances. And, similarly, the funders and, reviewers need to kind of think about this and understand it. I think, the other thing we're looking on is toolkits more for rapid adaptation. Again, I don't think there needs to be any more studies that are asking the same questions that we've learned about features, overall global features. We need to be more, thoughtful about what are the tailoring features, what are the unique things that impact the likelihood of behavior change in these specific populations that can make our interventions better and more effective. We don't need to continue to recreate the wheel. And I think, we miss opportunities to really gain information from our populations by starting off with the same things of what features in an MHealth intervention would you want, and do you want it to be confidential, and is it okay if we send you a reminder? Assume yes, to some extent, right? And then figure out much more about the nature, the timing of the reminder, or a feature that you really think is going to actually change the behavior you want to change. And then we need to obviously just do much more around scale up and dissemination. Again, it really is critical that we, think about all of the different, partners and people and users and funders and partnerships, that we can be making to start to scale up. So in final concluding thoughts, again, I think, we talk about ending the epidemic, or, whether it's, in the US or even globally, I think, again, so much of this is transferable. It does require an intentional, integrated, personalized approach, which maximizes the likelihood of engaging key populations at each stage. I do think technology-based platforms offer a potential way to deliver some of these integrated strategies in an engaging, impactful way. I don't think they replace the human touch. And I don't think every intervention, as I said from the kind of first few slides, is meant to be an MHealth intervention. I also don't think MHealth interventions are, meant to be kind of seen as a silo. MHealth is required for any intervention you're going to do with youth is going to use MHealth in some way, even if it's just reminders for coming to study visits, social media for recruitment and et cetera. So it is a part of everything we do if we're doing any study on youth anywhere in the entire world. So we need to embrace it, and we need to continue to figure out how youth are using it, so that we can continue to meaningfully engage with them. Again, I think these projects and programs can have the capability to improve lives, but I do believe that we just haven't seen the current impact that we should and can see. And I'm really excited about thinking about the future and about this next level of again building on all of the really things that we know about how to treat, prevent, and potentially cure, right, HIV, and using our digital health strategies as a way to bridge and engage and implement these these amazing kind of discoveries and breakthroughs. And again, I think that, to maximize this potential, we need to be thinking more about moving out of our silos, moving away from kind of the build anew. And health empowerment isn't the only platform out there. So this is not, it's not a sales pitch, but I think, as a whole, researchers, we need to do a better job of working together, both kind of across, different spheres of HIV and at different, disciplines, but also in other behaviors. And we really need to think more about, transforming, from just these standalone tools to platforms that are much more responsive to the lives and the needs of the populations we're serving. So I will end on that with 10 minutes left still, I think, to spare for questions. And again, too many people are too important to me to include their names, which is, I guess a cop out in some ways, but it's just everything I do is a collaboration. And the people I work with are amazing, and I learn from every day, including all the people in my lab who really run the studies. So I really just thank everyone and appreciate you all tuning in and listening.
Thanks, Lisa. That's awesome. Seriously, I feel blown back to the back of the theater. I was like, totally wow. So first off, thank you for doing such amazing work at organizing a field that has really sprouted up over the past decade or so. Your work in this is really remarkable. And I appreciate your openness and willingness to share how you can bring your work to boost the next phase of work within this realm. I really do appreciate that. I'm going to take the bully pulpit here and take the advantage of just asking you the question. So it sounds to me like a lot of the interventions that are in MHealth are mature. So in thinking in the same way of like, a lot of our behavioral interventions are mature as well. We don't need to go back and re-show that CBT is effective or whatever. So, I'm wondering it sounds to me like this data, this MHealth package you have is the compilation of best practice. So what is the next round? Is it that system interference in real-time intervention work that's going to take us into the next more impactful interventions, or where are you thinking of moving next?
Yeah, I think that's where we are moving, right? I think, like I said, it's it's for any of our interventions, it's like it's like finding the right ingredients at the right time when with the right people that have enrolled in your study, and sometimes we don't understand why something didn't work or worked for somebody or didn't. Similarly, it's the same thing, with our digital health. It's like, sometimes it's just getting the right group in, getting them engaged right away or sending them the right message. And so I think, again, more and more, we're trying to, again, think about more kind of, like I said, just in time, more adaptive interventions, more understanding really what is the push-pull, what are the right levers and when should they be pushed and pulled. I think, these interventions aren't also addressing some of the structural issues that, that a lot of, that are impacting kind of, the outcomes. And so is there a way, I think, to also think about how technology can bridge some of the sort of the structural level things? I know Kathy Reback has been thinking about that quite a bit, but, I think that's the next stage is moving this forward.
So on that note, there's a question about where's the service desk. So if people want to work with Empower, where your program, who is the person you contact and how do you get engaged with you and your group so that you—
That would be me. You just,
okay.
We're not, like I said, we're not, I sound much more important than I am, but, it's me, it's Amy, who is we just gave her the title of program manager, and we just, it's a one-off, like I said, we're not, we're working through like thinking about how, again, even with the software company, like, they need to not be in the red. I'm always, we're always in the red, right? We work, 20% effort for, that's how we live and breathe, but they can't. And so we're really trying to figure out, I tell them like, no, you can't, charge, like, we have to, this person only has $25,000, like, because they have a K. We need to figure out how to make it work, like, and then like, okay. And so, but it goes through us. We usually meet and chat and figure out like, what is it that you need? What is it you want? And is health empowerment the right solution? If it's not, maybe there are other things that I have heard of or know of, or people that, I can at least have you talk to, because it's not the right solution for everything. And it can't do everything. And it's, it has a lot of things I wish we could do better, and I'm hoping in time we will, but there's a lot of other great platforms out there too.
Wonderful. A question comes in asking, is there a way that you have connected your program, your digital health intervention with, say, other providers that are out there doing technology delivery of, say, PrEP, like Nurex, or other sorts of companies that are funded and have a mission to make money, but are out there to do HIV testing or PrEP delivery or whatever?
Yeah, I mean, again, in all transparency, I haven't had that much luck with folks wanting to engage. We tried to engage PlushCare in some work with us, which is, again, similar to NERCs, and no shade to them, but they have a successful model of what they're doing, and we were trying to engage them to work with us, particularly at the beginning of COVID, because of knowing that they were going to be providing PrEP to folks in our clinics where we were enrolling and recruiting from, and so yeah, they have not, it was not a sell. I did hawk my wares to even pharmaceutical companies, and if they were interested in building off of it, and their I should say their feedback to me was around that they really weren't interested in such a highly customized, tailored application, that they kept things kind of much more broad, and and really, again, it wasn't a niche that they needed. Although, yeah, like I said, there's some pieces of some of the apps of some of the companies that was named very similar to one I presented to them, but I'm not saying that they took it, because that would, but yeah, if we're always open to doing anything, honestly, that would make sense. I mean, the grant we did put in was a small business award grant with a company that was going to help do this, the content management and develop this content recommendation system. And so that's kind of been our next step. We'll see. We just submitted it like a few days ago, but that would be a little bit more in the world, that the business world, than I live in.
Great. One final question, and there are a set of questions here that we've been keeping, and we'll forward them to you, and you can respond, and we'll get them back to our participants in today's Grand Rounds.
Or you can email me directly. I think my email was on, I think the slides will be posted, right?
Yes.
And it's on the last slide, so feel free to email me anytime.
Wonderful. Are you aware of, or did you identify factors that inhibit the implementation of MHealth your MHealth interventions? For example, your HMP from an ecological perspective. Was there any sort of rural?
Yeah.
Urban?
Yeah, we it's interesting. I mean, we've been doing, I have she was my postdoc, and now she's working at Penn with Jose Bauermeister. And we've done a lot of work trying to look at paradata and do sort of latent class analysis of engagement, and trying to understand profiles of users, which would predict high or lower use, or use of different components, right? Usage, like I said, engagement is so complex, which is really exciting, but and in one of the interventions using health empowerment, nothing really washed. It just was sort of like, there was nothing that was really predictive of it. In this newer version, again, it does look like perhaps race, ethnicity may be associated with use. Perhaps, again, it's early. It was literally an analysis that was just run like a few days ago. Maybe something around education, although again, in some of our studies, we're seeing much more higher educated folks enroll in the beginning anyway. And so we're really trying to look at that in terms of what predicts engagement. I also have a grad student that was looking at it from a syndemics perspective, and so not just sort of singular factors, but if there was syndemics that impact engagement, and so including neighborhood factors, looking at zip codes and things like that. So more to come. Again, I think this is it's really important that we make use of all of this data in a much more meaningful way, and look at our paradata before we just build the next app. And so that's, I'm really hopeful that within ITECH, we'll have so much paradata that we really can start to understand it, from a much more broad perspective than just each individual intervention, as one metric of engagement, if that makes sense.
A tour de force. You are remarkable. Thank you for coming here today.
Thank you.
I wish we could have dinner or something and continue to have these conversations. Exactly.
I mean, you do. Well, I'll eat, but but drink. But
I
you
know.
had me at drinks.
Yeah,
So.
yeah, exactly. But so it's great to see you. Thank you very much. We have this recorded, and with your permission, we'll post the slides. And thank you. And for those on the line still, please fill out the evaluation form link. That is the way we make our money. I see Kathy. Did you want to say something?
Hello, my dear. Good to see you. She's technologically
muted.
challenged.
I know. It's like, I know,
That's
right?
Kathy.
It's me too.
I love her. I love you too. I know that's what you're going to say. So.
I don't know.
All right. Call me.
All right. We'll see you guys.
Bye, y'all.
Be well.